I'm Dr. Kerry Hoggett. I'm an emergency physician and also a clinical toxicologist. This is 5 on Friday, and I'm going to be talking about some of the newer drugs of abuse that are starting to make their way onto the streets. So, to start with a case, you're called to see a 28-year-old man who's going a bit ballistic in public. He's agitated, he's semi-naked, he's running in front of cars, and is quite agitated and paranoid and distressed. When you get there, the police are there and say that they know this guy and they think that they know that he's a intravenous drug user. When you actually get to assess the chap, he's agitated, he's quite paranoid and psychotic, he's tachycardic with a heart rate of 140, his blood pressure is 160 on 95, his temperature is 38.2, he's quite sweaty and has big dilated pupils. He's quite difficult to control and his behaviour is quite unpredictable. So one of the things to think about with this guy is what's your differential diagnosis for this particular patient and what's affecting them. There's a number of things to consider. Obviously there are non-toxicological diagnoses that could contribute to this person's presentation. Things like a meningitis or a sepsis or an intracerebral bleed such as a subarachnoid hemorrhage potentially could cause altered behaviour of this nature. Obviously being a toxicologist, I'm going to focus on the toxicological differential diagnosis. And there are a number of things to consider. Obviously the most common one to think about is going to be amphetamines, and somewhere between 1 and 2% of all of our ED presentations in Perth are related to the use of amphetamines. They are either smoked or injected or snorted, and there's a number of different amphetamine derivatives that can produce quite similar effects. We're seeing an increase in the use of crystal meth particularly, which is the crystallised and highly potent form of methamphetamine, and that's certainly starting to be quite common on our streets. As well as the amphetamines and the traditional amphetamines, there are a number of other newer drugs that we can consider as part of or potentially contributing to this presentation. Probably one of the other more common ones are what's known as cathinones. So cathinones are amphetamine derivatives, and they're a synthetically manufactured substance which is actually based on a plant toxin that is quite popular in particularly northern Africa from a plant called khat, where chewing the leaves actually gives you a bit of a stimulus. There's a number of cathinones which are starting to appear. One of the more common ones that we've seen in the past is something called mephedrone, which is also known as meow or meow meow. Other possible cathinones would include things such as the benzopyrazines, and what is starting to become more commonly talked about is the new drug called flakka. So flakka, sometimes known as Bloom, is a cathinone derivative, and certainly looking at pictures and videos that are available on YouTube, it looks to be quite a compound that really produces quite scary, agitated behaviour, which can be quite difficult to control. Fortunately, to my knowledge, we haven't had a case where that's been proven in Perth yet, but like most things, it's probably only a matter of time that we will start to see it here as well. Other possibilities to describe this particular presentation, the synthetic cannabinoid receptor antagonists, so things like chronic, spice, K2, and then some new ones called things like mind rape. People who smoke these synthetic cannabinoids can actually have a toxidrome which is much more like an amphetamine type toxidrome than it is like a cannabis toxidrome. We see that they become agitated, they become hot, hypertensive, sweaty, and it's often because the structure of the synthetic chemical that they're smoking is actually a lot more similar to the structure of amphetamines or serotonin or adrenaline in the body system than it is to cannabis. So we see that a lot of their side effects are actually more related to that structural similarity to amphetamines. And finally, alcohol intoxication could potentially be partly related to this sort of presentation as well. And a lot of people do actually lose their ability to behave appropriately when they're under the influence of alcohol. So there's quite a wide toxicological differential diagnosis for this particular presentation. What are some of the life-threatening problems that you can actually develop, these patients can actually develop as a result of their drug use? There's quite a wide range of those. Death is actually quite common and certainly not a rare event in the context of the use of these stimulant amphetamine-like drugs. Other complications that can be potentially life-threatening are things like myocardial infarction. People can either dissect their coronary vessels or dissect their aorta as a result of the severe high blood pressure and possibly a weakening of the or early atherosclerosis as a result of chronic drug use is possible as well. Cardiac arrhythmia is also really common, either obviously a tachycardia, but that can then progress to things like a VT or a VF and cardiac arrest. You can also get an acute cardiomyopathy, which as a result of this kind of overdrive of amphetamine stimulation of your heart. And as a result, you can actually go into failure and you can develop acute heart failure and pulmonary edema. Some of the other things that really worry us are the neurological complications. So a number of patients, even with just once-off use of these sorts of drugs, can potentially have intracerebral hemorrhage of some form, which may or may not be lethal, but certainly affects their long-term health as a result of that. Other things, the psychosis is actually really common, and as we're sort of looking into drug levels related to that, we're seeing that the levels of amphetamine can actually be quite low at the time that psychosis sets in. So it's obviously much longer lasting than the duration of the amphetamine use itself, and it may persist for several days. One of the common things that we see is that people then get involved in trauma, or they think that they can fly, so they jump off stuff and end up with significant trauma, which can be potentially life-threatening as well. Other complications, particularly with the use of ecstasy and MDMA, patients can actually have seizures as a result of dropping their sodium really quickly and having a significant hyponatremia. When we're thinking about other complications, particularly of the synthetic cannabinoid receptor antagonists, often we will see patients who develop acute renal failure or develop a rhabdomyolysis or other complications as a result of chronic or even occasional use of this particular drug. One of the things that really worries us, and often what causes death from the use of amphetamines, is actually a severe hyperthermia. And so patients who have a lot of muscle overactivity become very stiff and rigid. They produce a lot of heat from that overactivity of the muscles. And as a result, they can't modulate their temperature appropriately. And we certainly had a number of deaths in Perth from severe hypothermia secondary to these stimulant type agents. And essentially what happens is your body gets so hot that all of your body systems shut down and you basically melt. So you break down your muscles, you damage your kidneys, you affect the way that your blood clots, you affect your heart and lung function, and basically everything just kind of melts to the point where you can't survive anymore. And certainly with a temperature of more than 42 degrees, really your mortality is based on your time that your core body temperature is over 42 degrees. So we're quite aggressive in managing patients who are hot to try and prevent those particular secondary complications and death from being super hot. So how do we manage these particular patients when they come to the emergency department? It's really about looking after yourself, looking after your staff, making sure that the patient doesn't come to any further harm, and often will require sedation to actually reverse some of those stimulant effects of the drugs that they're taking, but then also to allow them to, or to prevent them from getting those secondary complications. In the field, patients may well require physical and or chemical restraint to actually make them safe enough to transport to hospital. If you're not in a situation in the city where you've got access to sedatives, then perhaps an alternative method of transport may actually be more appropriate, and maybe it is safer to actually involve the police and transport the patient in a way that's not actually going to cause increased risk to yourself and to the rest of your staff. If you are restraining a patient, you shouldn't be restraining them face down. Often patients that are restrained face down are actually at high risk of developing airway compromise, which may well go undetected in the patient that's being restrained face down. There's also been cases of patients that have had a cardiac arrest while they've been being restrained face down as well. So it's a good idea, if you're going to do that, to avoid that particular position. In the field, IM sedations with midazolam may be much more safe than trying to put an intravenous line into someone whose venous access may not be very good due to chronic drug use. So injection of IM midazolam is probably a reasonable method to actually try and sedate the patient to make them safe to transport to the hospital. If there is significant agitation present, as an ED we always would like a heads up about those patients, because it does actually take us often a while to move cubicles around, to gather enough staff to restrain the patients, to draw up the drugs, and to find a place where we can actually look after the patient safely. And sometimes that actually takes a few minutes. So if you are bringing a patient into the ED that is quite agitated or has been quite agitated, we always prefer notification if that's possible, just to allow us to really set up to receive the patient safely and continue their care from there. Thank you very much.